Dear audience, I'm pleased to present my PhD topic about risk factors for pancreatic cancer and share my progress over the past 9 months. My name is Zsófia Román and I'm a nutritional scientist, and currently I'm working as a clinical research administrator at the Institute of Pancreatic Diseases, and I'm also a PhD student. Our vision is to improve the prognosis of pancreatic cancer, saving years of life lost. And to be able to do that, our mission is to explore the association between glucose metabolism alteration and diagnosis of pancreatic cancer. To achieve those goals, I have 2 ongoing projects. In the first one, we would like to understand the association between hemoglobin A1c levels and pancreatic cancer, while my second project focuses on patient characteristics and prognosis between early and late onset pancreatic cancer. So my first project is investigating the effect of hemoglobin A1c level on the onset and risk of pancreatic cancer. Pancreatic cancer is predicted to be the second leading cause of cancer-related mortality by 2030. The expected increase in mortality rate can be due to the delayed diagnosis, as we lack a predictive factor for pancreatic cancer. What is known is that type 2 diabetes mellitus is a risk factor for pancreatic cancer, where 1% will develop pancreatic cancer within 3 years from the diagnosis. However, what is not known is the dose-dependent association between hemoglobin A1c levels, which is a marker for glucose metabolism, and the risk for pancreatic cancer. Therefore, our aim in this study is to investigate the association of hemoglobin A1c levels and the risk of pancreatic cancer. Related to this topic, our clinical question is: how do different hemoglobin A1c levels influence the risk of developing pancreatic cancer? We would like to analyze in the adult population the different levels of hemoglobin A1c, and our outcome would be the risk of pancreatic cancer, and the secondary outcome is the age of onset of pancreatic cancer. And we believe that a higher hemoglobin A1c levels increase the risk of pancreatic cancer. As for the clinical implication, understanding hemoglobin A1c's role can help in the early detection and in the management strategies. We led a systematic search in 3 different online databases with the following search key. The first domain includes the different terms of pancreatic cancer, while the second domain focuses on hemoglobin A1c. During my search, I didn't find any meta-analysis related to this topic. This table contains my 3 key articles with a different hemoglobin A1c levels but the similar outcomes, which are that a higher hemoglobin A1c levels could lead to a higher risk of developing pancreatic cancer. I would like to highlight 3 articles from my included studies, which I will tell in detail. So in this study highlights that regardless of whether diabetes was diagnosed before pancreatic cancer, there is a clear association with dysglycemic hemoglobin A1c levels, such as in pre-diabetes and diabetes ranges, showing that an up of 6.5% hemoglobin A1c level was associated with an 8.55 times higher risk of developing pancreatic cancer. In this another article, the data shows a significant association between hemoglobin A1c levels and development of pancreatic cancer. However, this article also emphasized that besides hemoglobin A1c levels, other factors may influence the prognosis, diagnosis of pancreatic cancer, and these were not explored. In this article, despite a relatively narrow range of hemoglobin A1c levels, a significant increase in the incidence of pancreatic cancer is observed between 6.1 and 6.7% of hemoglobin A1c. However, this article did not examine the role of antidiabetic therapy, which represents a limitation. This is the flowchart of the selection process. We started with nearly 9,000 articles, and after the duplicate removal, we had around 7,000, and out of those, we selected 50 eligible ones and 3 articles from the citation chaser part. Based on our clinical question, we would like to do the following analysis according the found articles, which numbers can find next to the outcomes names. This is the current progress of my first project, and together with my co-investigators, we have completed the data extraction table, which now includes 46 articles, and in parallel, we finished the risk of bias assessment using QUIP's tools, and the first version of the table has been sent to the statistician group, and I will participate in the booster class next week. Regarding the secondary outcomes, I sent emails to the authors to request individual patient data to analyze the relationship between hemoglobin A1c levels and the age at the diagnosis of pancreatic cancer. And currently, we are waiting for more responses. So my second project is comparing the patient characteristics and natural history of early and late onset pancreatic cancer. Pancreatic cancer is becoming an issue. It is still unclear which factor influenced the prognosis in relation to age. Unlike most cancers, pancreatic cancer affects not only the older generation, but the younger one as well. Therefore, we can categorize into two major groups as early and late onset pancreatic cancer. Early onset pancreatic cancer is defined as pancreatic cancer diagnosed before the age of 50 years, and it has been increasing over the recent years. It's typically driven by inherited and lifestyle factors. On the other hand, we have late onset pancreatic cancer, where typically somatic mutation drive the disease. Therefore, our aim in this study is to understand the characteristics of early onset pancreatic cancer and how it affects treatment outcomes and overall survival. Related to this topic, our clinical question is: what are the characteristics and prognosis of pancreatic cancer associated with early onset? We would like to analyze in the adult population and compare those with early and late onset pancreatic cancer, and we would like to see the different population-based characteristics and the prognosis. As for the clinical implication, understanding early onset pancreatic cancer treatment responses could improve our current guidelines and potentially the screening processes as well. We use the following search key to find my key articles. The first domain is same as in my first project, while the second domain focuses on early onset. During my search, I found a systematic review related to this topic, but no meta-analysis. This table contains my 3 key articles with the different population characteristics and prognosis. During my search, I focused on finding prognosis relation to different therapies. As a summary, my projects focus on patient characteristics, and we would like to know how they affect the disease. My aim is to submit my first project by September 2025, while my second project by September 2026. At the end, I would like to quote B.B. King: "The beautiful thing about learning is that no one can take it away from you." Thank you for your attention.
Thank you very much. Nice talk. Is open for discussion. Any questions from the audience? Yes?
Congratulations on your presentation. I have a question regarding to your first project. During your analysis, are you planning to do a subgroup analysis as well?
Thank you for your question. We are planning to do a subgroup analysis. Our first thought was under 5.7% of hemoglobin A1c is meaning no diabetes, and then between 5.7 and 6.4 is pre-diabetes, and then up or equal with 6.5% of hemoglobin A1c. So it was our first thought, and then we had a conversation with a specialist, a dietitian, and based on her ID, we would like to do another subgroup like under and below 7% of hemoglobin A1C, because based on her ID is more relevant in clinically. Thank you.
Thank you.
More questions? How do you want to diagnose the cancer? What method do you use to screen these patients? Because, you know, it's the major point, which is the most sensitive.
For example, before this presentation, I had a conversation with this dietitian, and she told that if she met a patient with higher hemoglobin A1C levels, she immediately thought that something with the pancreas. So this is the first way. And another that I'm...
Sorry, but this is quite a personal observation.
Yes.
Not much evidence for that.
And another that what I could say that I'm working as a clinical research administrator at the Pancreatic Institute, and I used to work with the pancreatic registry as well, and I met with the patient on Monday and on Tuesday, and they come to us a visit with a solidum, and they had CT or MRI. It's not acceptable the ultrasound because we couldn't use this, and then the patient go to this to the oncologist, and then we have a multidisciplinary meeting to discuss with a radiology, surgeon, oncologist, and basically the next step.
That's okay, I understand that, but you know, the diabetic population is quite a big number, and so if you want to screen them for pancreatic cancer, to detect cancer early, how do you plan to do that? Well, it costs a lot of money.
It's a complex thing, because when we had this idea with the hemoglobin A1C, my team reflects that it's not just, so we have to we have to investigate more factors, not just hemoglobin A1C levels. That's why we would like to do a multivariable model analysis when we investigate not just hemoglobin A1C levels, but adjust it for BMI, smoking or alcohol consumptions as well.
You plan to use some tumor markers?
No, we won't.
Okay. Thank you.